what is likely to work or not, right? Rather than what we result to in many cases, which I would call human experimentation, right? Trying to figure this out after the fact. And particularly when you're talking about surgical interventions that are permanent, this is a real issue. So just talk about Ghrelin here for a minute, since obviously Ghrelin has been hypothesized to be an important component of what happens after bariatric surgery, and obviously been hypothesized to be an important component of the hyperphagia that goes along with Prader-Willi. So if you look at what happens in terms of levels, I'm going to go through this very quickly, and I'm not going to give you the details of the experiment. But if you look at what happens after a Roux-en-Y gastric bypass, and when you look at active Ghrelin levels, we see no evidence that Ghrelin levels are actually reduced after Roux-en-Y gastric bypass. However, after a vertical sleeve gastrectomy, again, which got referred to as a restrictive procedure, as you pointed out, not really a restrictive procedure, what you see is, in fact, you do lower the levels of active Ghrelin. So what we went on to do is now is take this data, which has been generated a number of times in different situations, and now actually test the hypothesis. Is it the case that if we can't lower the Ghrelin levels, that will reduce the impact of the surgery, right? In this case, of vertical sleeve gastrectomy. So this is an animal model of vertical sleeve gastrectomy. What you can see right here, animals that get a sham procedure versus animals that get a vertical sleeve gastrectomy. And these are wild types. Now look at the Ghrelin knockouts. So the Ghrelin knockouts are leaner, right? Because Ghrelin does matter, right? So if you take away Ghrelin, the animal ends up leaner. But what you see is that the response to surgery is almost identical, right? In fact, if you look at fat mass reductions, here's the fat mass reductions in wild types. Here's the fat mass reductions in animals who are Ghrelin deficient. How about glucose control? So here what you see is the top two lines, right, are animals that get the sham procedure. Here are the two groups that get vertical sleeve gastrectomy. Whether you have Ghrelin or you don't has very little impact on whether, in fact, you respond to it. Now, this isn't the right model to ask the question about what's relevant for Prader-Willi and potentially other syndromes, right? Because this is a model that says changing Ghrelin levels is not necessary for the outcome for vertical sleeve gastrectomy. What it doesn't say is whether in the face of high Ghrelin levels, right, is a particular procedure effective like vertical sleeve gastrectomy. So I have two take-home messages for you. One is, my lab is absolutely happy to work these issues down in any model that you think recapitulates key parts of any of these syndromes, right? And ask this question in a rodent model and gives us some data before we go into human trial. The second is the point of bariatric surgery is not just to treat the hyperphagia, right? It is not just to treat the resultant obesity, right? It is the comorbidities that go with that resolve, again, for vertical sleeve and Roux-en-Y and biliopancreatic diversion, that resolve at rates that can't be explained by the weight loss alone. They are profound interventions around the biology, not just about the circuits that control food intake, but also all these other aspects of the physiology and biology that contribute to chronic and long-term metabolic diseases that are associated with increased weight. I will mention very quickly at Tony's urging, we have done vertical sleeve gastrectomy in a rat model of MC4 complete deficiency, and the data look exactly like this. That is, you can't tell the difference. If anything, again, the effects are larger in the MC4 deficient animals than they are in the animals that are wild type. So with that, I will stop, and again, appreciate all of you for indulging me with this opportunity to talk to you about data. And again, my offer for models to come in that we think that we can test in this way, we are happy to do it. So thank you very much.
This meeting has folks with expertise that I really have enjoyed hearing about. I'm a pediatric surgeon at Cincinnati Children's Hospital, and my interest in obesity treatment goes back about 10 years now to when I first arrived there as an assistant professor and was faced with kids that come to really the pulmonologist, come to the diabetologist, and so forth, and we're not really getting modern care for their morbid obesity, and we're instead having to have problems treated that I thought we could do better with. Now, that's entirely different from the kids with hyperphagia and the hyperphagia syndromes, and that's what I've just come today to share a little bit of our most recent experience with. So this is this the last? Yeah, this is the last. This is just what I'm calling a CCHMC update. From our center, over the years, we've really only treated 6 patients with hyperphagia syndromes, and these are really all craniopharyngiomas. Now, the first patient, the 15-year-old at the time of tumor diagnosis, is shown on the far left. And I've just shown a few of the characteristics that I think matter to an audience like this. He was had panhypopituitarism, and then presented for bariatric surgery 3 years after his treatment of his tumor. His BMI was 67, and he had a terrible quality of life at that point, and severe obstructive sleep apnea. The delay between neurosurgery and GI surgery was then 3 years, and he underwent a gastric bypass. But before he underwent a gastric bypass, we really called around quite a bit to figure out what to do, because again, this was our first patient that we had treated. And I called around to see, was there a national experience with treating such patients, and what should we offer? And are there care paradigms that we could benefit from? And really, there wasn't a lot. There were a few veteran surgeons that gave me a few tips, but nothing in the literature that really could guide us. Well, we actually studied him in the GCRC in a number of simplistic ways, and I'll share a little bit of that with you, and noted that his lowest BMI, he lost about 100 pounds. His lowest BMI was 52 at 24 months. And then at his last follow-up, which was 75 months, so just over 6 years, his BMI had maintained at about 53. So we thought that this 21% weight loss was a reasonable success. His quality of life was reasonably better, but his parents had told me about his demons. And unfortunately, he succumbed to an addictive problem soon thereafter, this last visit. But as I mentioned, we did some studies, and this kind of shows you, if you look in the right upper quadrant, you can see and kind of get a grasp for his just extraordinary insulin excursions. Preoperatively, in the black, you see insulin levels in the fasting range that were 20 or 30, and postprandially, this is just a meal challenge, going up into the 200 and 300. So this is a log scale for insulin. And then just following the lines down, we studied him at 10 days, 7 months, and then again at 14 months in the GCRC with meal challenge studies and serial blood draws over over 24 hours. And you see that his hyperinsulinemia responded fabulously as early as 10 days. The fasting hyperinsulinemia was markedly improved. And then by 7 months, and certainly by 14 months, he really just had very small excursions in response to a meal. And so this is, again, after gastric bypass. What we also did, because we had the benefit of the Seeley group and the CHOPE group at the time, Matthias was in Cincinnati as well, is we ran total as well as active Ghrelin and leptin. And you can see here, there's a lot of noise in these Ghrelin assays when you look at one patient. But suffice it to say, if you really look and summarize the pre-prandial versus post-prandial, there was a marked decline in the pre-prandial level, about a 50% reduction, rather, in the mean pre-prandial Ghrelin level compared to the post-operative pre-prandial Ghrelin level. So there seemed to be an effect, and again, if you believe me with that. Leptin was kind of interesting. Within 10 days, before any major weight loss, we saw a dramatic reduction in his leptin profile as well, as shown in the graph, and then subsequently at 4 months, even lower levels. So probably some of you can explain that a lot better than I, but I think there is a relationship between insulin resistance and leptin levels, aside from just the fat depot. So I really just came to tell you about the remaining subjects as well. They're patients that we've treated, and these are their ages really at the time of tumor diagnosis: 10, 12, 11, 3, and didn't have that last one for abstraction. And then their ages at bariatric surgery, all of them essentially teenagers, a 20 and a 21-year-old as well. We've done mostly Roux-en-Y gastric bypasses. We've done 2 VSGs. The BMIs at bariatric surgery you can see there as well, 35 to 68 essentially. And it's interesting, the 35 BMI was the next patient we did after that first patient I mentioned to you. The mom happened to be a nurse in a nearby city and had actually seen that case report and said, you know, I've got a daughter, a beautiful daughter. She's gained a lot of weight after her craniopharyngioma, and I'm afraid, doctor, I'm afraid to let her get to, you know, a BMI of 60. So she actually came at a BMI of, say, 32 or 33, and we worked with the family, and indeed she did get to a BMI of 35. And we agreed that she would be an appropriate candidate. She lost in 12 months to a BMI of 23 and really has maintained that weight loss. And so I really consider her a success for, from a health standpoint, a quality of life standpoint, and, you know, a switched-on mom, as I would call her, someone who really, you know, ventured into a territory that we still know very little about in terms of the long-term response, but was really quite impressed with the fact that after gastric bypass, we can expect really only a 35% weight loss in general obesity. A 35% weight loss then translates into, you know, a healthy BMI if you're not too late in the game. If you're at the, you know, BMIs in the 60s, you do the math. The 35% only gets you so far. So I really do have respect for her courage and her decision-making at that point. So I don't want to prolong this too far. I think we can cut to the quick and really just look down and believe me when I say that I really don't know what the right answer is because the percent BMI change, I think, at the various times of follow-up that you see there really do, you know, distribute around a spectrum. This is a heterogeneous disorder. In many ways, the pathways are not the same. You know, the interruption in the pathways because of the tumor and the treatment are heterogeneous. And I think that surgery will predictably have a heterogeneous outcome. So anything that we can do to learn more about the response to surgery, the appropriate type of surgery, I think that we have an obligation to do. I was talking to Frank Greenway about, you know, what about this 18-year-old who's now struggling after having lost from a BMI of 45 to 36 at 2 years and is now back to a BMI of 42, a 4% reduction. So I really don't come here and, you know, thinking that surgery is the answer, and don't apologize to me about the BPDs. I certainly am in agreement with you that we shouldn't be doing surgery that have such enormous nutritional risks. But I do really think that that people in this audience and the people that really study these syndromes should certainly be encouraged that surgeons are eager to hear about research, eager to hear about protocols that we might be able to enact. And I would hope that, you know, my colleagues, the surgical colleagues, would be willing also to collect data and try to, you know, hone in on what are the important research questions and what are the how can the research inform the clinical care paradigms? Because right now, as again has been mentioned, we see an awful lot of papers emerging that are doing 1 or 2 or 3 cases and having very unpredictable outcomes. The one last comment I'll make is that part of our effort to really think about what can we do to sort of organize research efforts in this area. In a condition that's rare, you really have a hard time finding enough cases to study if you have this great, you know, research idea. So what we decided to do is to spend a little bit of the American Recovery and Reinvestment Act dollars on a registry. And so what we are doing is trying to register patients who have hypothalamic obesity disorders and who are interested in participating in research, and also register investigators that might be finding that population useful and try to make connections. It's almost like the research match that, you know, those of you familiar with that out of Vanderbilt. And so this is just some quick screens. It's very minimal data that's collected. We went through a process, first in our institution, I'll be happy to say, of an online consenting process for families. So we got through all the IRB hurdles and we're the first to ever do that apparently at Cincinnati Children's. for online consenting. We collect, basic medical history. What is the condition that put them at risk of hypothalamic obesity? And then what is their treatment? Are they pan-hypopit, for instance? And then what has been their response to surgery if they've had surgery? And then this is just the medical professional side for registering people that are interested in perhaps using this population that we're recruiting. On the website, there's an easily downloadable PDF so that you don't actually have to go about registering people. You just hand them a flyer to register themselves at the website. So with that, I will thank you for the time and certainly be happy to take any questions, unlike my rude colleague, Dr. Seeley, who just ran right out the door.
So I'd just like to say thank you first of all. Should I move? Is that better? Yeah? So first of all to Jim and Tony for asking me to talk. So my name's disappeared off this slide, so I hope that's all that's disappeared. But I'm going to talk to you about a project that I've been working on with Tony Holland about vagus nerve stimulation. It's a project that we've just finished, actually. So just to start with what it is and why it might be useful for those who don't know. It's a surgically implanted device. It's a small generator that's implanted in the upper chest, and then electrodes are tunneled under the skin and attached to the vagus nerve in the left side of the neck. And the generator sends electrical pulses to the nerve in the neck. It's currently licensed for therapeutic use in epilepsy and depression. But as you'll know, the vagus nerve is also crucially implicated in the satiety signals from the gastrointestinal system to the brain. And VNS increases the afferent input from the vagus nerve. So in line with this is quite a body of evidence of weight loss or appetite alteration in animals. However, there's fewer studies that have considered the effects of VNS on weight and eating behaviour in humans. So this is just a table of the studies that I've identified that consider weight loss or eating behaviour in humans in a systematic way. There are other anecdotal mentions in other papers. And all but one study concerns patients undergoing VNS for the treatment of epilepsy and depression, with the weight outcomes generally retrospectively reviewed. But it's clear there's some evidence across the literature. It is a bit mixed. It's mixed with the different pre-VNS weights as well. There's some suggestion that a higher pre-VNS BMI might be associated with greater weight loss. So the hyperphagia in PWS arises from the delayed and short-lived satiety, but crucially the satiety isn't absent. So if we can increase the satiety signals somehow, then it may be possible to boost it. It might be malleable. So the reported effects of VNS on weight and the importance of the vagus nerve in satiety suggested that vagus nerve stimulation might be useful in Prader-Willi syndrome. And this is what we've been looking at with a proof of principle study with just 3 adults with Prader-Willi syndrome. And they've had vagus nerve stimulation for between 18 and 31 months. So very briefly, a couple of outcome measures. So first of all, VNS was found to be safe, and it's been really well tolerated in these individuals. Any safety concerns have been fully explored, and VNS safety confirmed. First of all, as you'll see here, participant 1 has gained weight, which is not exactly what was anticipated. We don't actually think that the VNS was physiologically responsible for this weight gain. First of all, we did some gas exchange measurements with VNS on and off, and there was no change in basal metabolic rate. And as you can see here, when it was turned off for a brief period, the white area, the weight gain continued. We believe it might be possible that VNS had a psychological effect, whereby the participant felt she no longer had to take as much care about what she was eating. This participant in particular lives in an environment that gives her quite a lot of food freedom. Participant 2 has actually shown very modest weight loss. It works out as about a 2.93% decrease on his body weight from the mean baseline measurement. And although it's small, this decrease has actually been at the expense of fat mass with an absolute increase in the lean mass. But his diabetes has been poorly controlled as well, so it's quite hard to disentangle the causes. And participant 3 has shown relatively stable weight throughout. And the second set of graphs is we did a measurement of eating behaviour during an hour's free access to food, how much participants ate. and they continue to eat a high amount. So it's not looking good, but participants 2 and 3 reported marked changes in everyday eating behaviour, including occasions where they were happy to miss meals, and unexpected alterations in food routine were okay. For example, one of the anecdotes that one of the parents will give is they went to the dentist's appointment was at lunchtime, and she expected all hell to break loose when she said that they were going to the dentist, or at least to take a pack up, and her daughter said, okay, that's fine, we'll eat later when I get home, which would have been unheard of before. These 2 individuals would have had a huge outburst at these kind of events. And they will tell you that it's made a huge difference to their lives, and that of their carers as well. So in fact, there's these behavioural improvements that actually, in terms of what Linda was saying, have extended beyond the food-related outbursts to other changes in routine as well. The other participant 1, the one that gained weight, has not really shown such behavioural effects, but according to her and her father, she didn't have the same behavioural issues in the first place. She has a much more placid temperament, and the arguments about food just aren't often there. And the last thing to say really is that there was we also carried out some semi-structured interviews with participants just about it was quite a demanding study, so it was just about their participation experience, and all were glad they'd got involved, and the 2 participants that have had the effects on their eating behaviour and their behaviour have decided to keep their VNS on despite the fact that studies ended, because they were adamant they didn't wish to turn it off. And that's it really. Just thank you to a few people, particularly Tony Holland, who couldn't be here today. And that's...
So, any questions?
Surgical intervention with a clear placebo effect.
No, it was just in the 3 adults, just as a proof of principle to see before any sort of bigger study. The problem with the placebo control with the VNS, and it's actually quite hard to do because a lot of people do feel the stimulation, and there are things that will indicate that the VNS is on, like voice hoarseness. Occurs in an awful lot of people during stimulation.
Yes, but you can certainly adjust it to change the amperage and the frequency and the shape of the curve, so that you could at least have done a dose-response curve, because the expectation is that a lower stimulus, which is not detectable, would have shown less effect. So, because otherwise what you've done is a classic open-label trial where you don't know what you're seeing.
Well, the idea as a proof of principle and a proof of concept was just that it was an open label, it wasn't placebo controlled. That would be part of a larger study. It was switched on in the first instance at 0.25 as a standard, and then it was incrementally increased up to a maximum of 1.5.
I'm sorry, could you repeat that again?
So the vagus nerve stimulator was switched on originally when it was first switched on. We had baseline phase measurements when it was off. And then it was implanted, then we had a baseline phase of 3 months with measurements every month. And then it was switched on at 0.25 milliamps. And then it was increased each month by 0.25 milliamps up to a maximum of 1.5.
I don't want to monopolize that. We'll discuss this later.
Okay.
Yeah, Linda, you know, I think the world of your behavior management techniques, but the one thing I do disagree with you is when you say reward, not hunger, drives Prader-Willi syndrome. And I don't think I'm the only one that disagrees with that. I think reward has a place in that, as it does for all of us. You know, like most of us overate last night, I'm sure. But you know, there have been fMRIs that show that our kids stay hungry longer. It takes more to satiate them, and they get hungry quicker. And I'd like Dan or Merlin or Tony maybe to comment. Is Tony? Yeah, Tony, why don't you comment? You're up there, or Ann perhaps, on that question.
Let Linda defend herself first.
Yeah. I don't think, first place, you don't know that the fMRIs are actually showing hunger, and I'll let them discuss that because that's their expertise. I didn't mention why we think that as much as I meant to, and that is that we get many, many reports of individuals who are fasted for some reason, miss a meal for some reason, but they have food security. They know they're going to get what they're going to get. They know when they're going to get it. As well as individuals who are depressed or individuals who are just plain, excuse the French, pissed off, and they'll go on a hunger strike. Our caretaking group home colleagues all confirm that they have seen these hunger strikes. Parents often comment that when the family misses a meal, the individual with Prader-Willi syndrome is quite comfortable. When we saw these individuals on 600 calories a day losing weight quite rapidly, I would ask them about this. My impression was that they were much more comfortable in losing weight than typical people are. So I can give you lots more. I admit it's all anecdotal and we'll never be able to get inside their heads. But there are so many reasons, and there are many in Europe. I met more people who had come to the same conclusion independently of us, that hunger is not actually increased, but that the lack of satiety combined with the enhanced reward experience seems to be driving this.
I think I'd say that the two are probably both there. I think the two are inherently linked. I mean, hunger and hedonics are very tightly linked. Certainly, the amazing ability for the patients when the food security is there in group homes to be so much calmer and happier. And if it was just a hunger situation, which one presumes doesn't change, if you put them in the environment where the food security is there, one would expect worsening behavior, but we don't see that. We see improving behavior in that food security environment. The case I showed of the magic drug, which was actually the magic group home, that patient is incredible. I mean, the temper tantrums were going on at home when she had unlimited access to food were much, much worse than the behavior and I don't think our hunger has changed, but the environment has changed. And I think when Jack was talking about what defines hyperphagia, I think this issue about the stress around it is seemingly a very important part. And I think if you take that stress element out of it, the behavior becomes much better, even though I doubt we've changed the hunger. So I think there is hunger there, but I think the problem behaviors come out of the stress and maybe some of the reward emotional responses rather than the hunger per se.
One other comment is with the hypothalamic obesity, the food security principles are needed and they're useful, but they aren't nearly as effective. It's so dramatic how well the food security principles work for Prader-Willi syndrome, less so for the hypothalamic folks whom I regard as truly hungry.
Other comments? We can take the mic around, or somebody can come up here.
This is making good on Tony's request for the unpublished and the anecdotal. We have a growing experience in operating on kids for the scoliosis and Prader-Willi. And one of the things that I've been finding is that these are kids who typically wake up from surgery crying because they're hungry, because they want to eat and they're not allowed to eat. After a big surgery, you get an ileus. It means that everything kind of goes to sleep for a while. It takes a few days before. In general, you can feed kids. Prader-Willi takes longer. And sometimes they get stomach distension. We put an NG tube down them. In those kids, when you put an NG tube down, suddenly the behavior completely changed. They no longer are asking about food. They are much easier. They're much more docile. And we've actually had some kids who've had an NG tube down for 2 or 3 weeks and who in the past were real behavioral problems. The parents have all pointed out, it's really interesting, that complete cessation of food craving.
I'll comment on that. I take all the medical calls at the National Prader-Willi Syndrome Association, and we've had 2 situations, I know, where kids who are tremendous food seekers, when they were put on TPN for one reason or another, totally lost their appetite, didn't talk about food, didn't ask for food, were totally fine with not eating, but once they were taken off TPN, they were right back to where they were before. So I wish there were a way we could do a study on that. I know it's hard to get IRB to approve putting kids on TPN for no reason, but it's an interesting mystery.
Do you know if those kids had, the ones in the
No, it was TPN, no NG tube. So, but still, there's something there. There's something to look at there. I'm not sure. Any more questions for the participants?
I'm just going to ask one, if I may. You showed a few patients with bypass and a few with sleeve gastrectomy. I just wondered, A, what prompted the decision between the two, and even if it was just random, what are your feelings about those two procedures that maybe out of the little bit of consensus that we've come up with, it's looking like gastric banding isn't such a good idea, maybe we're agreeing that, and that therefore our two procedures are sleeve gastrectomy and bypass, and therefore what would prompt us into choosing between those two procedures from a surgical point of view?
So yeah, good question. We so I don't think it's random. I do think that in our center, at least, we prep the families for pros and cons of this operation, that operation, and including the band operation. We'd say that we don't offer the band because of the FDA regulations for most of our patients. But for sleeve and bypass, we really don't know the answer. So we present it in a very balanced way, and then the theoretic advantage of the sleeve for teenagers with the reduced concern for micronutrient deficiencies, along with the nascent data from the adult experience, and even midterm data showing a fairly nice effectiveness against comorbidities and weight. If we're leaning one way, I think we're probably leaning toward the sleeve. At least my dietitian would certainly be answering that affirmatively. And we have seen a reversal from our most prevalent operation, a few years ago was bypass, to now 4 out of 5 are choosing VSG now. So in the special forms of obesity population, again, I can't claim to know any better how to counsel them other than to say, this is what we know.
I have a question for Tony. So for the drugs that you mentioned, like to treat the hypothalamic obesity, does it apply? Is it effective for all types of the obesity, or it's only effective in a certain types of the obesity that caused by genetic mutation or not caused by genetic mutation?
So which drugs did you mean?
I think the last one, the ZFN201.
Sorry?
It's the Bariatric, I think.
Sorry, I can't.
Methionine.
That was me. That was Frank. I think the question is your
Beloranib. Beloranib.
Is that effective for all forms of obesity, or just for hypothalamic obesity, or?
Yeah. Well, beloranib's just finished the phase 1B trial, which was 4 weeks long. So and the phase 2 trial is just starting. I mentioned it because it seemed to address both the issues about hypothalamic obesity, the energy expenditure and the insulin secretion, but in animals it seems to reduce weight down to the weight of the wild type animals that have leptin deficiency, for example. So although it's thought that because it does address serious obesity, that it may be best developed for that purpose, but it looks at this point from the animal studies that it may be widely applicable.
I think we're at the end of this.
Can we just do one more thing? Can we poll the audience to see how effective our arguments were? Kind of like a debate.
That's not fair, Ann.
How about in general, just for time?
In general, okay. So hands up those who think we're completely realistic, think that we will never find a drug. And let's talk about drugs that are not targeted to the specific mutation. Let's talk about general drugs that the similar Frank talked about, or supplements, whatever work in genetic or hypothalamic obesity. Hands up. So who is realistic and does not believe that drugs that aren't targeting the specific mutation, drugs in general for obesity will ever work in hypothalamic or genetic obesity?
That they won't work. That they won't work. Ever won't work.
Okay. Hands up who believes they will. and who is on the fence? I think the optimists win by a sliver. Okay, so
That was more in a sliver, Tony.
who believes that, I'm going to be a bit more strict because I don't want to lump all the studies together. Who thinks that gastric bypass or sleeve gastrectomy, and I'm going to split it into two things here, has a role in, firstly, Prader-Willi syndrome? Who believes it has a role in the management of Prader-Willi syndrome? Who doesn't? Who's undecided? Good, we have consensus. Okay, in non-Prader-Willi syndrome, so we're going to include craniopharyngeal and MC4R mutations, and maybe the disorders. Who believe that sleeve gastrectomy or woman gastric bypass have or may have a role in the management? Who believes they do not? I believe it consensus, and who is equivocal? Good.
You forgot the NG tube for Prader-Willi.
Oh. NG tubes and TPN for Prader-Willi. Who's hungry?
It's time for a break, 15-minute break.